Hi, everyone. My name is Jessica Allegretti, and I'm the medical director of the Crohn's and Colitis Center at the Brigham and Women's Hospital. And today I'm going to be reviewing Clostridioides difficile infection, diagnosis and management. Here are my relevant disclosures. And the learning objectives for today's talk include discussing the epidemiology, diagnosis, and treatment of primary C. diff infection. We're going to review the mechanisms of disease and treatment options for recurrent C. diff infection. And then we're going to review sort of all the latest with fecal microbiota transplantation and the new emerging class of medications called live biotherapeutic products. So let's start with the scope of the problem. C. diff remains the most common cause of healthcare associated infection in the US, with an estimated 500,000 new cases in the US annually. There are several risk factors for initial infection, including recent treatment with antibiotics, exposure to healthcare or long-term care facilities, immunosuppression, inflammatory bowel disease, even in the absence of immunosuppression, elderly age, and PPI exposure. If we think about the microbiology basics of this disease, this is an anaerobic, gram-positive, spore-forming, toxin-producing bacillus. And so it is spread via the fecal-oral route, which is why we always talk about hand washing and mechanically removing those spores from your hands, because you are swallowing those spores all the time. Only under the right circumstances in the gut will that spore vegetate and release a toxin. And it's actually the toxin that makes you ill, not the bacteria itself. Most disease-causing strains will produce toxin A, B, or both, and these just cause a lot of cell destruction and death. So think mass apoptosis. And when we talk about pseudomembranes, that's really what you're looking at is essentially a pus bubble. We know that there are more virulent strains, such as NAP1, that can produce up to 20-fold the amount of toxin. And so when patients are infected with these strains, they tend to be fulminantly ill and often in the ICU. Now, the diagnosis is based on the presence of diarrhea, which is defined as the passage of 3 or more unformed stools in a 24-hour period. I often will ask my patient, if I was to put your stool in a cup, would it take the shape of the cup or would it have its own shape? Because that's really what you're getting at is unformed stool. But you also need a positive test. Now, let's go through C. diff testing because I find this to be sort of the more nuanced aspect of caring for these patients, because not all C. diff tests are created equal. So we're going to go through 3 of the most commonly sent tests and talk about what they actually mean. So the first test you may encounter is the antigen test. This is also called the GDH test, which stands for glutamate dehydrogenase. This is an enzyme produced by all C. diff isolates, both toxic and non-toxigenic strains. And so this is really a first pass screen. This is telling you about, are there organisms present, yes or no? The next test is the toxin test. This is also called the EIA test or EIA toxin test. It's an ELISA-based test that is actually looking for the presence of toxin, often both toxin A and B. Now, the early versions of this test were felt to have very poor sensitivity, and so there was concern for high false negative rates. That being said, the newer versions of this test are much better. They're not perfect, but they certainly are better. However, because of this concern for high false negative rates, many institutions turn to PCR only or PCR confirmatory testing. Now, why is this important? So often the test is not called PCR. What you'll see is toxin DNA testing. Although you may see those big PCR panels as well. And so what information does this test tell you? It tells you about the presence of genetic material that codes for toxin. So it is telling you about the presence of a potentially toxigenic organism. It is not telling you about the presence of toxin. And so if you only have a PCR test in front of you, you cannot distinguish colonization from active infection. And so at my institution, for example, we've completely gotten rid of PCR testing because we don't find that it actually provides any additional information. And so there is guidance on this. No commercial test should be used as a standalone. You want to be using a 2-step testing approach. You want to start with a highly sensitive test that could either be your GDH or your PCR, because both of those tests tell you about the presence of organisms. If that is positive, you'd move on to the toxin test to actually look for the presence of toxin. And if both are positive, then you've confirmed infection. If the first is positive and the second is negative, that patient may be colonized and you may need to look for other sources of their diarrhea. Some important caveats. If the patient is already on antibiotics, when the test is sent, you may have a false negative assay, even with a single dose of vancomycin. And so if there was a high enough clinical suspicion for C. diff, you may just need to treat through. You don't repeat test. If the testing is negative today, don't test again tomorrow. The testing characteristics are quite good. And we also don't test for cure, as the test can often remain positive. And so cure is really defined based on symptom resolution. So how do we treat? Well, metronidazole and vancomycin were previously the treatments of choice for an initial episode of C. diff infection. Prior to the year 2000, failure rates for these antibiotics were essentially identical. After the year 2000, we start to see failure rates for metronidazole really start to increase. And so the IDSA guidelines came up with a new set of guidelines in 2018, and they actually updated it in 2021. And what's notable here is that for first episode C. diff, whether it's severe or non-severe, vancomycin and fidaxomicin are preferred. Metronidazole is no longer considered a good first-line agent for C. diff. And I can actually tell you, I can't even remember the last time I used metronidazole to treat a C. diff infection. What's notable here in the update in 2021, the IDSA came out and said that there is actually a preference for fidaxomicin over vancomycin as a first-line option. I was actually part of the ACG guideline, which came out in 2021. And this does look quite similar to the IDSA guideline. Notably, vancomycin and fidaxomicin are considered preferred first-line agents for primary C. diff, whether it be severe or non-severe. We actually did review the data at the time of the IDSA guideline update, and we hold the stance that both either vancomycin or fidaxomicin are appropriate first-line choices, and really metronidazole has fallen out of favor. An important point about vancomycin is that the minimum inhibitory concentration against vancomycin, meaning how much vanco do you actually need around to adequately suppress C. diff, is 1 to 2. With the standard dosing of 125 milligrams Q6 hours, you can achieve fecal concentrations of 350 to 400. So what does that tell you? Doses greater than 125 milligrams Q6 hours are not likely to improve the efficacy of vancomycin. So if you have somebody who is having diarrhea despite appropriate dosing after about 72 hours, C. diff is probably not the cause of their diarrhea, and you need to look for another cause. There really is no appreciable resistance to vancomycin reported to date with C. diff, and so there really should be no scenario in which you're increasing to the 250 or 500 dose. Fidaxomicin is a non-systemic, minimally absorbed bactericidal antibiotic. Vancomycin is bacteriostatic. The FDA-approved dose is 200 milligrams twice a day for 10 days. When these two were compared head-to-head in a non-inferiority study, fidaxomicin was found to be non-inferior to vanco. However, if you look at the actual data, fidaxomicin was better at preventing recurrences and better at achieving overall global cure. What about non-antibiotic therapies? Patients are often asking us about probiotics. This is taken from the ACG guidelines. We recommended against probiotics for the prevention of C. diff in a patient being treated with antibiotics, so primary prevention. And we also recommended against probiotics for prevention of C. diff recurrence, secondary prevention. So really, there's no instance in which probiotics are helpful in this scenario. They don't prevent a primary infection and they don't prevent recurrence. I think a lot of the tide started to turn on probiotics when this study was published in 2018 in Cell. This was an animal model that looked at 3 groups. So all of the models were given a Cipro, and then they were divided into a group that got probiotics, an autofecal transplant, or just left for spontaneous recovery. And what was found here is that compared to spontaneous recovery, probiotics induced a markedly delayed and persistently incomplete microbiome reconstitution. So you actually might be doing harm by giving somebody probiotics after an antibiotic course, as opposed to just letting them recover on their own. And so how do we actually measure treatment response? Again, you want to see that frequency and consistency are improving. This should occur about 3 days after starting antibiotics. I always remind patients that uh, often you won't snap back to completely normal right away. Some people will, but often you'll have more frequent or slightly mushier stools than normal because post-infection irritable bowel syndrome is a very real entity. And so I do a lot of counseling about that upfront. So now let's switch gears and talk about recurrent C. diff. Recurrent C. diff is the recurrence of symptoms after a successful initial course of therapy. So the patient took their vancomycin, they felt well, and then days to weeks later, the diarrhea comes back unprompted. Now, we know that that can be from persistence of the same endogenous C. diff spores as opposed to acquisition of a new strain. Now, we don't typically do strain level analysis when we test because it doesn't change our management. But when this has been assessed, the vast majority are reinfected with the same serogroup. Again, so they're probably not disinfecting their homes properly, and there's a huge spore burden around when they're microbially vulnerable. The window of recurrence is 8 weeks. So again, after the antibiotic course is complete, days to weeks later, most commonly this occurs between week 1 and week 4, but we do follow patients out to 8 weeks. Once you have a first infection, your first recurrence, rather, your second, third, and fourth become exponentially more likely. So it's sort of a roller coaster these patients can't get off. So why does this happen to some and not to others? Well, we know it has to do with an impaired host response and also an altered intestinal microbiome. So I think this study really illustrates the host response aspect quite well. These are patients that were admitted to a hospital and were exposed to C. diff. The serum IgG antibody response to toxin A determined how likely patients were to be an asymptomatic carrier as opposed to develop diarrheal illness. And similarly, the IgM response to toxin A determined how likely patients were to develop recurrent disease. And so seeing data like this, it's not surprising that several companies have attempted vaccine trials. However, none have been successful to date. We also know that an altered intestinal microbiome is really critical. And we know that you want a lot of phylogenetic richness. You want a lot of functional redundancy to your microbiome. And so you want to be up here in this upper right corner. And you can see in blue, that's where our healthy controls are. By the time you have an initial infection, you've taken an antibiotic that gave you this infection and you're being treated with more antibiotics. So by the time you have recurrent disease seen here in green, you really have a paucity of phylogenetic richness. You've really been sort of ablated. And so why does this matter? Well, it's not just which bugs are present, but really, again, the functions that they're performing for you to maintain your health. And we know that the microbiome ferments short-chain fatty acids, performs lipid metabolism, protein digestion, and really critically for C. diff infection, bile salt metabolism. And so again, just to review, C. diff is communicated by the ingestion of spores. So if you're eating or drinking something right now, you're probably swallowing them. They're part of our environment. These spores can live outside of the gut. They're resistant to heat and antibiotics. Inside the gut, under the right circumstances, they will germinate and become vegetative cells, which produce the toxin. So without germination, you never will get a C. diff infection. That's that critical step. And we know that bile acids are vital to the germination process. So again, at a very high level, primary bile acids are made in the liver. They're excreted into the gut, many of which will get reabsorbed in the small intestine after they help you break down fat and circulate back. A very small percentage will end up in the colon where they'll interface with the gut bacteria, several of which have enzymes called bile salt hydrolases, which will convert primary to secondary bile acids. And that's what happens in health. We know that if you were to put a bunch of C. diff spores in a petri dish with secondary bile acids, they inhibit growth. So this is a mechanism we've developed over time to keep spores in their spore form. However, if you were to take an antibiotic, say for your tooth abscess, ablate those critical members of your microbiome that have those bile salt hydrolyzing enzymes, you know how to have a gut that is enriched with primary bile acids. And we know that primary bile acids stimulate germination and toxin release. And so when we first explored this in human samples, what we found was that there was a nice increase in those pro-C. diff primary bile acids across the disease state from healthy controls, first episode C. diff and recurrent C. diff, and a decrease in those protective secondary bile acids. We also saw that just by looking at the bile acid composition in the stool, we were able to fairly accurately predict which patient group the patient fell into just by looking at the bile acids. And so I should say we're now using this to prospectively assess looking at bile acids as a potential biomarker to predict recurrence. So how do we actually treat recurrent C. diff? Well, I would say the big teaching point here really is do something different. If you treated with vancomycin initially, use fidaxomicin or a vancomycin taper. By the time you're on your second or further recurrence, you need a treatment plan, which is always antibiotics, and a prevention strategy. And that could be bezlotoxumab, FMT. There are several, and we'll review them. So again, from the ACG guidelines, there are 3 prevention strategies that are really outlined: FMT, which we'll discuss further, bezlotoxumab, and suppressive vancomycin. So suppressive vancomycin certainly could be used for a population that is either not eligible for an FMT, maybe depending on their goals of care, patients who are comfort measures, patients who get a lot of recurrent antibiotic courses. Tapering down to a daily or every other day single dose of vancomycin actually can be quite effective to suppress further recurrences. But we also have bezlotoxumab. This is a fully humanized monoclonal antibody that binds to C. diff toxin B. A lot of people ask about toxin A. Toxin A was also studied and did not work, and so they discontinued that program. And so this is administered as a single IV infusion, and it is indicated to prevent recurrence, not treat. So it is meant to be given with a course of antibiotics. You can give it at the first day or the last day of the antibiotic course, but the patient must be given this while they're still on antibiotics. So now let's dive into sort of our most popular preventative strategy, which is FMT. FMT is the installation of minimally manipulated microbial communities from stool of a healthy donor into a patient's GI tract. And so this is really how FMT is distinguished from a defined consortium of microorganisms or probiotics, because it's not just bacteria. It's viruses, fungi, metabolites, everything that comes with whole stool. And because of this level of complexity, the FDA considers this to be both a drug as well as a biologic or tissue. This is still not FDA approved and likely never will be. The FDA still holds a policy called enforcement discretion, stating that we can use this clinically for patients with C. diff not responding to standard therapy, and no investigational new drug license is required. However, you still have to state that it's investigational and discuss real and theoretical risks. This is an area that's constantly evolving. There was a draft guidance back in 2016, initially stating that they might enforce an IND requirement. Then in 2022, they in fact did enforce an IND requirement. And right now, the onus is on the stool bank, not necessarily the physician who's receiving the material from the stool bank. One of the issues with FMT is that we don't really know why it works so well. And so my lab was very interested in the bile acid hypothesis. And so we actually looked at bile acid composition before and after FMT compared to donors. And again, post FMT, we see a nice decrease in those pro-C. diff primary bile acids and an increase in those protective secondary bile acids. So restating bile acid homeostasis may be one mechanism at play here. So how effective is FMT? Well, it's very effective. It already has a very well-established role for the prevention of recurrent C. diff. It is ID and GI guideline approved in both the US and Europe. This is how you actually do it still to this day. We're still doing FMT. And so this is the 5D approach. So the first D is decision. Again, this is not FDA approved. So you do have to be really mindful about who you're administering this to. And so the patient selection is really important. Under the policy of enforcement discretion, it's patients with 3 or more confirmed episodes. There's also a role for this in patients with fulminant C. diff, even if it's their first episode, again, because they are not responding to standard antibiotics. Some important considerations: if the patient has only ever had PCR testing and they're not responding to vancomycin, again, consider other etiologies. That patient likely has another source for their diarrhea. We know that the younger the patient is, the more likely they are to have an alternative diagnosis, and you really do want to confirm this before you perform an FMT. Who's inappropriate? I still won't do this in patients who are neutropenic. We'll wait for count recovery. Any evidence of bowel perforation. Chronic antibiotics for me is not an absolute contraindication, but it does mean that the patient has a higher likelihood for FMT failure, and so that should be part of your informed consent. Donor selection, I think most of us are using a stool bank model currently, in which you either are partnering with an external stool bank, such as Open Biome, which is still open and operational, or you have an in-house stool bank where you have your own group of donors that you're routinely testing. Patient-directed model is sort of what we used to do, where you would pick one donor for one patient and have to screen that donor on a one-to-one basis. And you can imagine that was very costly and time-consuming. We used to think fresh was better than frozen material. After this head-to-head trial was done, we now know that with regards to efficacy, fresh and frozen are equal, so we can bank samples and thaw them out for use. This is the minimum screening requirements for donor stool per the FDA, although I can tell you this is certainly not an exhaustive list. This is the minimum list. And I'll just note here that the MDROs, or multi-drug resistant organisms, are now on here as well. So let's talk about the pandemic. As with every aspect in medicine, FMT was affected as well. And so when the pandemic hit, initially material that was produced after December 1st, 2019 was not eligible per use for the FDA. It had to go into quarantine. At that time, OpenBiome implemented SARS-CoV-2 screening of asymptomatic donors. So with nasal swabs, stool testing had to be developed and validated, and that took about the whole of 2022. But now stool is also tested for the virus as well. That being said, there are no reports of transmission of this virus via FMT to date, although that was an initial concern because we do know that it is shed in the stool. Which leads us to the third D, discussion. How are you actually going to consent patients for this? So again, acute concerns are things like infection transmission. With screened material, this really, there have been actually very few reports of this. But I'll share some data that happened in 2019 that really changed a bit how we think about this. That being said, the long-term consequences remain, I would say, a bit unclear, though clearer now than ever. So the question was always, are we predisposing the patient to a disease that the recipient may eventually develop? There are several microbiome-associated diseases now. And so, again, we do extensive donor screening, but what if the patient hasn't developed that disease yet? And so partnering with the AGA and the NIH, we're doing a national registry in which we're following patients for 10 years. And so far, we haven't seen any safety signals to date. So with regards to infection transmission, as I just alluded to, in the summer of 2019, the FDA reported 2 immunocompromised patients developed a systemic infection with an ESBL E. coli after FMT, and one of the patients did die from this infection. The donor notably had not been tested for ESBL prior to the FMT. These were done in IND-approved protocols. And also notably, these were not done for C. diff infection, but again, clinical trials, one for graft versus host disease and the other for hepatic encephalopathy. So very immunocompromised populations. Ultimately, the donor was found to be ESBL colonized. And I should also mention, this was not done using Open Biome stool, but an in-house stool bank at a single university. And so scenarios such as this emphasize the importance of meticulous attention to donor testing for potential pathogens and really just the need for standardization across the board. Other infections of concern, EPEC and STEC are other strains of E. coli. Stool has always been screened for EHEC and STEC, traditionally via an enzyme immunoassay. EPEC has never been felt to be a pathogen and so has not traditionally been screened. And in fact, in Europe, they still don't screen for this organism. However, in the beginning of 2020, there were 4 cases of STEC and 2 cases of EPEC that were reported post-FMT, all resulted in self-limiting diarrhea. However, because of this, there was new guidance from the FDA to screen for all of these organisms using PCR testing. The fourth D is delivery. How do we actually deliver the material? NG or ND tube is not really done anymore, though if you read the older literature, this is how this was traditionally administered. Retention enemas are still done and quite a bit in pediatrics. Lower endoscopy, full colonoscopy, or flex stig, I would say is still the mainstay in the adult space, and we also have capsule preparations as well. So where you deliver the material does matter. Upper GI tract is not as good as lower GI tract, and actually right colon administration is the best with regards to efficacy. So how do you actually do this? If you were doing this via a colonoscopy, the recipient would do a standard bowel prep. We know there is actually something therapeutic about the bowel prep with regards to removing any residual spores and any residual antibiotics that are still around. If you were doing a patient-directed donor, you would just have the donor poop essentially on the day of the procedure. We try to collect within a 6-hour window, and the samples don't necessarily need to be frozen. You would blend the stool and with normal saline and strain it until liquid and draw it up into 60 cc syringes. And essentially you can flush it through the scope. And so this is what it looks like when you're prepping your own material. And again, you just end up flushing it through the scope, just like you can flush water through a scope. This is to just contrast what it looks like. This is the older formulation of Open Biome, which was 250 mLs. It's actually much more concentrated now, but it comes already strained in liquid form and frozen. And so you just thaw it out in a water bath, and then you can do the same process, pump it through your water pedal or flush it through the scope. There are also capsule preparations. Not all capsules are created equal, so depending on the literature you read, again, they maybe have been prepared slightly differently. The pros of capsules are that you can avoid a procedure and anesthesia, so therefore lower cost. In theory, no bowel prep is needed, although as we're going to discuss with the VOWST data that was published, there may be actually some benefit to using bowel prep even with capsules. The cons are that these are large pills typically, and there's often many. And the dose is still somewhat unknown. We actually have never done formal dose finding studies with traditional FMT capsules. So this was the earliest version of FMT capsules that I worked on. This is with Open Biome. And so the concern was that when you put stool in a gel caps are designed to dissolve in aqueous solutions, as is stool. And so you don't want something that's dissolving from the outside in and the inside out, because we want these to be stable in the GI tract. And so in order to do that, a lipid layer was put around the stool, again, to protect the material so that when the gel cap dissolved, the stool would not be released until that lipid layer was released much lower in the small intestine. However, in order to get enough material into the capsules with that lipid layer to equal what we do in colonoscopy, we needed about 60 capsules. And so we enrolled patients in a trial in which we compared high dose to low dose capsule administration. So 60 capsules, 30 on 2 consecutive days compared to 30 on 1. And we followed patients for the standard 8 weeks. And what we saw is actually fairly equivalent cure rates with both doses. Anybody that failed was able to get redosed, and we brought the efficacy rate up to 94%. And so because of this very small study, the dosing for FMT capsules for many years was 30 capsules in a single dose. Now capsules are lyophilized, meaning essentially freeze-dried, and so you can get a lot more material into the capsule. And so the average dose of capsules right now is about 5. The final D is discharge. So how do we actually follow these patients up? Well, you want to remind them to not take any antibiotics home not take any antibiotics after FMT once they're at home, and put those away. We don't test for cure, again, for different reasons. We know that FMT actually very effectively decolonizes patients. And so unless there are new symptoms, there's no need to test. And we do a lot of patient education around cleaning high-touch surface areas, giving their house one more good wipe down, and antibiotic stewardship. The cadence in which we follow patients up is we have a touch point with patients within the first week, because there is a group who will be primary non-responders, meaning they'll have no response. The diarrhea will either continue or come right back immediately. We'll often bring those patients back within the first week and redo the FMT. There's also a group of secondary non-responders who will do well, and then somewhere between week 1 and week 4 have a relapse. We will always retest those patients to confirm that it's real, and if it is, we'll bring them back and repeat the FMT. Anything that happens after week 8 is considered a new primary episode. And so in our last couple of minutes here, let's just review this new class of medications, which are called live biotherapeutic products. And so there are many therapeutic products in development, two of which have been FDA approved, which we're going to go through in a bit more detail. Finch Therapeutics had product CP101, which is no longer under development, and Vedanta Biosciences has their first synthetic product, VE303, which is in phase 3 study right now. So I'm sure we'll be seeing more from them in the future. But let's talk about the two FDA approved products. So the first product that was approved was Fecal Microbiota Live JSLM, or Rebiota. It's indicated again for prevention of recurrent C. diff, not treatment. So this is meant to be given after a standard of care course of antibiotics. There is no indication in the label as to how many recurrences a patient must have. Traditionally, I think we're using this in the standard FMT population, although here is a list in this table you can see of types of patients you may want to consider using this earlier. So older patients, immunocompromised patients, patients with IBD, those who are really at high risk for recurrence. Even at a patient's first recurrence, you might want to consider using one of these preventative strategies. In the clinical trials, this product looked overall very safe, really very few contraindications, and the adverse events reported in the trials were really mild GI side effects, very similar to what we see with FMT. I will also mention that this is administered as a single rectal administration, or enema, essentially, that's done in office. So you don't send somebody home with this, you do this in the clinic. This is what it looks like. So it comes as a frozen bag. So it gets stored at -80, and you do need to thaw it out before use. It can be in the refrigerator for up to 5 days, and then we usually thaw it out prior to use. The patient will come into the office and either be in the left lateral decubitus position or knees to chest position. You administer it as an enema, let the liquid flow to gravity, and have the patient stay on their side for 15 minutes. Notably, there is also data on using this liquid preparation through a colonoscope, just like I showed you with the liquid FMT preparation as well. And that is certainly how I have used this product previously. We also now have fecal microbiota spores live, BRPK. This is also known as VOWST, formerly SCR-109. This is a narrow consortium composed of live purified firmicute spores. So the stool was essentially washed with alcohol, the spores were removed and encapsulated. This is an oral product taken as 4 pills on 3 consecutive days. And again, is also indicated for the prevention of recurrent C. diff, not for treatment. So it is meant to be given after a standard of care course of antibiotics with an appropriate washout in between. Again, no contraindications, looks very safe, similar to Rebiota, similar to traditional FMT. So if we're going to compare and contrast these two, again, fecal microbiota live, JSLM, is a single dosed rectal administration done in the office, can be refrigerated for up to 5 days, pulled out of the freezer, and should be administered after a 24 to 72-hour washout of those standard of care antibiotics. Whereas the fecal microbiota spores live is 4 capsules taken once daily for 3 consecutive days. This is a prescription that you will write and get sent to the patient's house. Should be taken after a 2 to 4 day washout. And when you prescribe this, the patients will also get sent a bowel laxative, so 10 ounces of magnesium citrate to take the day before their first pill administration, again, to wash out any residual antibiotics to improve the efficacy. And so our take-home points are that the incidence of C. diff is still increasing at an alarming rate. Metronidazole is no longer a good option for first episode of C. diff. Counseling about post-infection irritable bowel syndrome is crucial and will save you a lot of phone calls down the road. FMT is an effective therapy for recurrent C. diff infections. And it is still not FDA approved and never will be, but you are still able to perform this under the policy of enforcement discretion. However, Rebiota and VOWST are now approved for use with more agents coming. So thank you to all of my collaborators and my lab, and I look forward to the questions.